in Physiology and Masters in Medical Education. She is the head of Physiology Department and University College of Medicine and Dentistry, University of Lahore. With over 2 decades of experience in medical education, she has led innovations in artificial intelligence integrated learning, simulation-based assessment, and immersive role-play pedagogy, including the original METAFERS theory. I don't know about the abbreviation, but she can explain later on. She serves as chair of PBL Year 1 Year in Charge and is a key member of curriculum and assessment committees internationally. She is the country head of the Asia Pacific Association on PBL in Health Sciences and president of the South Asian Association of Physiologists. Her research includes a novel PTEN gene mutation in breast cancer and pre-diagnostic hematological markers with publication in Nature, which is a very famous journal, and 12 patent submission. She is a reviewer for the Advances in Physiology Education and associate editor of the Pakistan Journal of Physiology and co-director of the Sciences of Happiness course at University of Lahore. A very, very warm welcome to Professor Dr. Samina Malik. I also welcome our panelists, Professor Dr. Akhtar Hamid, who is a pediatrician, Toronto-based, attached with University of Toronto and working in different hospitals. And the queen of simulation, Dr. Jabin. I think she is everywhere, here, there. Very warm welcome to Dr. Jabin. So just after this introduction, I will hand this podium to you. And our most valuable participant, for your time, for your interest. You are with us for like 4 or 5 years. And our technical team to manage and run all these things. So a very warm welcome to all of you, my dear. And we have a QA window available in the Zoom. You can write down your question in the QA window. You can introduce yourself in the chat box with your LinkedIn profile. So it's all open, interactive, and me may be looking into this thing. So this is all available. My apology. So with this, it's over to Dr. Jabin for the next thing. Yes, Dr. Jabin.
Thank you so much, Dr. Azhar. Without further ado, I will pass it on to Professor Samina Malik, who is a very dear friend. I call her my soul sister. So over to you, Samina.
Thank you so much. And with this confession that whatever I have learned in simulation, I'm very comfortable because my teacher is here to handle everything. So thank you very much, Professor Azhar, for inviting me. And I'm highly, highly grateful. And I'm representing a low middle income country as well. So my focus will be on economical ways of using simulation, especially in South Asian countries, which are labeled as low middle income countries. But we all know that where there is a will, there is a way. And we also know, I hope I'm clearly audible.
Ji, Samina, you are clearly audible.
And my screen is also visible, right?
Yes, in our correct view, the screen is also visible.
That's perfect. Thank you very much. So, this necessity, is the mother of invention. And if you see at this screen on the very left side, you can see a traditional problem-based learning session going on. While in the middle, you can see that this is Dr. Jabin's session going on of simulation. And we were receiving this training from her from University of Lahore when she came to visit us. And on their right extreme side is another innovation going on. And this is a team of students from Nepal who are simulating as a simulated doctor, simulated patient, and the staff of the doctor in the hospital. So with the less, opportunity, there can be a lot of creativity. So this is the major purpose of this talk. And I'm from basic sciences. The field is physiology. And you know that physiology is the mother of medicine. And when we are training our students for problem-based learning scenarios or simulation scenarios, it is quite the same. So all over South Asia and also in the Western countries, the one thing that is common is problem-based learning. So using that problem-based learning in a more innovative way, in which the teachers, they will not become limited because of the limited number of faculty who have to create the scenarios for the problems or simulations. So the problem can be made easy if we empower the students and if we hand over this AI tool to the students. So they will be able to work on it in the beginning to write the scripts, and later on it can be improvised with the help of the faculty. And me and Dr. Jabin had this pleasure of, along with the president of American Physiological Society, Professor D. Silverthorne, the author of the book, we happened to hold this quiz last year, which was an inter-medical college physiology quiz. And in this quiz, there was an innovation used that we thought that let's move globally and teach the undergraduate students simulation by holding an awareness webinar and include this AI and simulation segment as one of the rounds of this physiology quiz that is on the go. And this was the fifth annual Intermedical College Physiology Quiz, which was innovated that way. With the help of Dr. Jabin as the simulation quiz master, and I facilitated her, and me myself as the AI quiz master, and then the physiology quiz master was Dr. Silverthorne. So after receiving some learning or basic certificates in artificial intelligence and in simulation, I thought that it should be used further and things should be innovated. So this is the basic summary of whatever I'm going to talk about. And please feel open to interact and post questions or comments whenever you want. And we would be open for discussion. So this conventional problem-based learning thing was paper-based, and still it is paper-based at many places. So you can see that if the scenario is written on the paper and the patient is not in front of you, or the simulated patient is not in front of you, or there is a dummy in front of you that is used for simulation, then it gives a different value. So instead of a paper which creates no source of empathy, so we can introduce this empathy segment in the problem-based learning sessions or in the simulation scenario sessions, which are quite similar to them. So especially in the resource poor countries like South Asia. And what we can do is that we can empower the students and we can make them critical thinkers. We can improve their history taking skills as well as their diagnostic skills, which will include the physical examination as well as the investigations. What are the relevant physical examinations and what are the relevant investigations for a particular case of disease that should be diagnosed accordingly. And then how to deal with the staff, how to deal with the nurse, how to speak to the operation theater attendant and to the patient's attendants and to the patient. So you will agree that a rough exposure will never be good. That is, if a student is not prepared and student is sent directly to a patient, a real patient, and the students they start laughing with each other due to their own jokes, then the patient feels offended because it is an immature stage of the students in first year. So, and you know that in the medical curricula, right from first year, now the exposure is being given to the patients. So in that case, it is very important that the patient safety is taken care of. And also it is a matter of safety on the part of the students as well. So their safety is also required, because then they can frequently ask questions, they can make mistakes, and they can understand that it is okay to make mistakes in a simulated environment, because they will be pre-briefed about it during the pre-briefing session, that this is a safe space and whatever happens here remains here, and no discussion will take place afterwards, and there will be no consequences. So if this type of a pre-briefing is happening in the pre-briefing room, then you can imagine that the patient will feel so safe. The subject, this student who is the now going to act as a doctor or going to act as a nurse or something, will feel very safe while facing the simulated patient, because the simulated patient will be able to speak, will have some expressions, will have some dialogues. So while dealing with them, and also while dealing with attendants, the attendant of the patient, who can immediately come in front of you and ask for anything, and they will have to tolerate, not only tolerate that attendant, they will also have to offer some counseling to that attendant and take care of that attendant without missing the care of the patient. So this kind of emergency handling, emergency dealing can be created in a scenario, and this scenario can be created with the help of artificial intelligence. And artificial intelligence, one of the tools that is very freely available and commonly practiced is ChatGPT 3.5 version, which is free, but now 4 is also available. So we used this version so that the students can be taught on it, so that they can create their own scenarios of the diseases that were offered to them, and they were allotted different diseases by toss and lottery, and then they were supposed to create those scenarios with the help of chat gpt, and based on certain standards. And the standard is International Nursing Association for Clinical Simulation and Learning. We call it INACSIL standards. This is a healthcare simulation standard for best practice that is used. So there are standards in it for pre-briefing, and standards for the simulation running, and standards for the post-briefing, that is the conclusion thing. So when the students were taught in the webinar that was conducted by Dr. Jabin in that physiology quiz, they were participating from 10 different countries of the world, including USA as well, and there were South Asian countries, Africa as well. So those students, they learned and understand something new, that on the basis of those standards, it makes a lot of difference to create a new script, which will be an improved version of the way the patient care is provided, because they are the best practice standards. So you know that with chat gpt a statement comes which says that garbage in, garbage out. So if you are putting in the right thing, then you are also receiving the right product. So if you are feeding through ChatGPT 3.5, the faculty can feed, the students can feed, that give me the all this scenario on the basis of NACSL standards. So for this particular disease, right, what should be the asked in the history, and how the pre-briefing should be like, and what should be managed in the simulation. And again, when they will be dealing with the patient in the simulation room, we based the standard, because they were undergraduate medical students, so we kept the standard up to the level of diagnosis. We did not include the standard of treatment or management. But you can understand that if the students are till fourth year medical students, then you can also include treatment. And if they are even final year medical students, senior students or house officers, then you can also include the management. So whatever you feed to ChatGPT, it will give you the same. And then you can manually even improve that by converting it on a Word file. And you can consult the textbooks, standard textbooks, and the reference books, even publications in good journals. So this way there will be a self-learning that can take place. And finally, further improvisation can take place by consulting with the consultants. So this way they can tailor-made their own, simulation scenarios. And because it's a huge effort and takes a lot of time, and we also received rigorous feedback. And finally, I will also discuss with you their feedback, because there's a lot of learning when we receive the feedback. So this tailor-made type of situations and scenarios or problems can be created this way. And once this much effort is taking place, then we can also ask the students, this is what we did, to make a video out of it, and a 20-minute video of pre-briefing, scenario running, and debriefing. And I will also make you witness one of those videos. So we have now a huge pool of those videos from those students who participated, and many of them have also offered them as a teaching and learning resource material globally, so that the global students and their faculty can be helped. So the video that the students created of pre-briefing, scenario running, and debriefing, it was later on evaluated, because it was a quiz, and in which there was some competition and reward. So it was evaluated on a quantitative as well as qualitative scale, that had total of 15 point score, and was a peer reviewed scale that was created by Dr. Jabin. So we use that for evaluation with the help of all other students of Dr. Jabin and me included. So what was the problem, and where is the gap, and what was the hook in this case? So one of the problems was that we are a resource limited country members, and we are depending on the paper cases. Although we have a simulation lab, not every institute can have a simulation lab, and we were dealing with global students. So in order to provide something simple, an easy solution, so we thought of creating this kind of a simulation setting, in which the students are empowered by this AI tool, and simulated, and they can use this AI tool to write down a script for this entire simulation scenario, pre-briefing, debriefing, on in Excel standards. And this is what was done, and the faculty was later allowed to improve it. So the students were normally developing apathy. There was lack of empathy among the students by going through the paper cases. They were just coming for attendance, and they were not achieving much out of that problem-based learning sessions in those countries. That is the countries of South Asia, which more or less share the similar curriculum. So there is a problem of having a simulated patient in the form of the dummies and models, and also the real patients. It is also difficult these days, because the real patients will be of less variety, especially in the private sector hospitals. There is a less patient load, and even if there is this patient load, then it is difficult to find variety, and then again it will be a practice, a long practice that the students will take, so that they become safe to handle the students, to handle the patients in turn. So the students, they were lacking the diagnostic skills because they were feeling emotionally insecure while taking history in their clinical settings. Usually when the student is taking a history, and the student is not mature and not focused, sometimes the students may annoy the patient, and then the patient safety will also become affected. And if the student is then scolded by a consultant, then the student's confidence is also shattered. So all these things are very important to be granted to the student with time and with maturity and with safety. So the gap was that there was lack of use of AI and simulation in this type of sessions in case of the curriculum of medical undergraduates of South Asia. And the hook is that students can be engaged if they are empowered, and then they will have some ownership, that they are the creators of their own, curriculum. So this way they felt empowered, and they were able to do a lot of experimentation and learning. So this was basically the aim, to empower them and to engage them and to enhance their diagnostic skills, to develop their critical thinking, and to establish some safe environment, safe learning environment where they are not judged. So the learning outcomes were firstly to develop a simulation-based scenario using artificial intelligence after the online orientation session or webinar that was held. Recording was also shared with them so that they could repeat it at their and watch it at their own pace. And then to design a simulation-based video script so that certain standards of an Excel are they are met, and then the students are able to keep it as a teaching and learning resource for the next generations, for the next batches to watch, and also for the sharing of resource material globally. And to perform successfully in this video, keeping the rubric standards, because the rubric was also shared with them, the rubric that I was just talking about, which had a score of up to 50 marks, and was a quantitative as well as qualitative scale. So these three learning outcomes, they touch the Bloom's taxonomy levels of 6 and 3. The population that was used was 25 international teams that were winning the first round of the Intermedical College Physiology quiz. And now they were exposed, these top 25 international teams, they were exposed to this webinar or orientation of AI and simulation, and they were empowered so that they create their own videos, which will be assessed later. So, and then they were assessed. So each team consisted of 3 members, and all of the 3 members, they belong to the undergraduate level. So later on, I will share with you that in one of the feedbacks, it was reflected that more members were required. So maybe next time they can be offered more members so that they can complete their team of doctors and different types of doctors and their team, which includes the paramedical staff as well, and the allied and all. So they could properly practice as a team along with the patient and attendant as well. So this was the intervention that we used AI and simulation, and we created the pre-briefing part and the scenario running part, as well as the debriefing part in terms of writing of its script, and then it was improvised. In Excel, standards were introduced in all the 3 steps. So this way the steps, they matured themselves, and they developed like they are created by some professional. And then the clinical disorders were allotted randomly for this competition using a pinwheel. All right. So the outcome was evaluated on the basis of that rubric that was already shared with the students so that they can also improve their quality standards and maintain them. And the feedback was later on obtained from the students, and feedback was also given to the students on their videos. And the score was also given and feedback was also given so that their learning should also take place. So this is how this assessment rubric looked like, and those 50 points, and there was a score of 1 to 5 with excellent performance for 5 and needs improvement for 1. So here you can see, like, one of the points is debriefing should have clarity and structure, and then learning objectives should have alignment with the rest of the scenario. And then the scenario should have some realism and relevance. Likewise, there should be good facilitation skills, and should be use of medical concepts in that video. Also, teamwork was scored and collaboration was also checked. Then the debriefing should be effective, and the students themselves, they were involved in pre-briefing as well as in scenario running as well as in debriefing, as if they are the consultants and they were everything. So, and finally, the creativity and innovation was also checked. So 2 more things were time management, because they were supposed to make a video of 20 minutes in which they were including everything. For that, editing skills were also embedded in it. besides camera handling, and the technical quality had to be good. That is, it should be audible clearly, and it should also have a good visibility and sound. So these are the future prospects that I have just submitted it for the IMEC RIME, and that is Ronald Harden Innovation in Medical Education abstract. I have just submitted before this, before appearing in front of you, because it was the deadline that I was meeting. And also we will be incorporating it in the problem-based learning sessions, and not only in the medical college, but also in the nursing college. And we would love to integrate the medical students along with the nursing students, so that they develop this discipline and mutual respect of working with each other, because today is the age of interdisciplinary medicine. So these were some of the references that we used, and one of them is the reference of a guest editorial that was written by me and Dr. Jabin after the end of this simulation course, and was published in South Asian Association of Physiologists Bulletin. So now I'm going to reveal one of the videos by the students at KIST Institute of Nepal. So here you go.
Hello everyone, I am Dr. Usha Chawal and I'll be a facilitator for today's simulation.
So just checking, I hope this video is audible.
Yes, it is audible, Samina.
Thank you. So you can see that the person sitting in the center is a student, and she is now acting as a facilitator of pre-briefing, whereas the two students sitting on the sides are acting as students in this scenario as well, and they are being pre-briefed by the facilitator, who is actually a student.
Simulation session. I'm so glad to have you both here and ready to engage in this hands-on learning experience. So before we begin, I'd like to take a moment to give a brief overview of what you can expect in today's program. So the pre-brief that we're doing now is designed to introduce you to the concept of simulation, what it really is, and then outline the objectives and ensure you're ready for the tasks at hand. So simply put, simulation is an experiential learning without putting the patient at risk. So in today's session, you'll be tasked with diagnosing a patient who is presenting with muscle weakness. And you'll be presented with a real person who will be acting as a patient. So our objective is to guide you through the critical steps of history taking, physical examination, and clinical results that you need to analyze. So you have access to the patient's medical history that can guide you through various questions, and also you'll be assessing the muscles of the patient. Throughout the session, you'll have different tools and information at hand, including this clinical hammer that you can use to examine the reflexes of the patient, and then you have the measuring tape that you can use to measure the size of the muscles. And also do not forget to look out for the lab results, especially the creatine kinase level that you'll find elevated, and the genetic testing results and the immunohistochemical staining results. So the ultimate goal is to make a well-reasoned diagnosis. Am I clear with you guys? Yes. Okay. And the session, including the pre-briefing, the simulation scenario, and debriefing, will be of around 20 minutes. And I want to emphasize that our basic assumption is that you are intelligent, that you're motivated, and that you're here to learn. And as a facilitator, I understand that it is not unusual that you feel anxious or overwhelmed when you're in the simulation scenario. So do not take this as an assessment. This is a learning opportunity for you, and you'll not be evaluated on any terms. So don't worry about making mistakes.
So what you are seeing is that the basic assumption has been revealed by this simulated facilitator with the students, that we are not being judged, and immediately a safe environment is provided to the students before even the students are going. And they are also given some hints about what they are going to face there in the simulation room, so that they do not become confused or tensed or overwhelmed. And they are given some space, and they will also be taught that in case of any episode of feeling overwhelmed, you can take time out, and you can simply tell a code word to the facilitator, like there's an elephant in the room, or elephant or aleph or something, and then you can just come out of the room and visit the next door, in which there will be a counselor for you, so that once you are again safely handled psychologically, then you can come back and rejoin. So this is the way, through INACSL standards, this pre-briefing happens, and you can see that the first year or second year medical students, they are following those standards.
So your effort and clinical thinking are what we value the most in this experience. So also remember, the most important thing is confidentiality. The confidentiality mirrors a real life patient confidentiality. So remember to not take this out of three of us, and do not share it with any of your colleagues. So
you can also see that professionalism and ethics are being taught right in the pre-briefing room, because the students are definitely at this age not mature people, they are immatures, and there's a tendency for them to discuss about the patient and even laugh about the patient when they are outside, and even in front of the patient at times. They may think that the patient will not notice it, but you know that the patients are very, very sensitive to it, and they would not like to be used as experimental animals, and they would always like that the safety precautions are given, while simultaneously the students are also being taught that this patient is not a real patient but a near real experience, so that they are not confused or uncomfortable, but they become comfortable, but simultaneously they are being taught so much so that they should show them some empathy and respect towards the patient. So they are receiving this training before they reach the simulation area, where the patient will be the simulated patient.
The simulation scenario that we'll do after the pre-brief, there'll be a debriefing session, and the debrief really is a guided reflection. So do you guys have any questions? Okay. So with that said, I'll leave you to the simulation. Remember to approach each step thoughtfully and carefully, and apply your clinical knowledge. And don't be afraid of making mistakes. Thank you.
Namaste. I have a 15-year-old patient presenting with a progressive muscle weakness. Here's the X-ray and report that I've got.
Thank you. Namaste. My name is Dr. Isha. I'm a physician. How can I help you today?
Namaste, doctor. I'm his mother, and today we are here to seek your consultation for his problem.
Namaste, doctor.
Can you confirm your age and your name?
Myself, Soilendra Asare, and I am 15 years old.
Okay. So can you tell me a little bit about what's been going on?
So you can see that there is zero cost for this simulation running, in which a patient is talking, a student is talking like a patient, accompanied by a mother, so giving it a more real touch. And then there's a junior doctor who took the history, presented it to the senior consultant, and now the senior consultant is taking more targeted history so that can approach towards the diagnosis. And then there will be examination after the history, and they will also look into the investigations, so that the diagnostic skills of the future doctors can be developed.
I'm having problem with my legs. It's been harder to run and walk lately, especially while going up stairs. I sometimes trip and fall.
Okay. So let's talk more about your symptoms. So can you tell me the site of the weakness, like which muscles are most affected?
It's mostly in my thighs or my legs.
Just in your thighs?
Yeah.
Okay.
So here also appreciate that the doctor is speaking at the level of the patient, who is not literate, like not from the medical field. So using the simple English terms for the patient, so that the patient can understand the language, and speaking in the language, cultural language as well of the patient.
So when did you first notice these symptoms?
Started about a year ago, and it's getting worse recently.
Okay. Can you describe the character of the weakness? Like, is it constant or does it come and go?
sensitivity for SAP, but it increases with more activity, and it improves a bit with rest.
Okay. So does this weakness radiate to any other parts of your body?
So you can see that the history of the weakness is being taken. I will skip it a little. And now you can see that the examination is going on.
Can you fill it?
And the muscle power, tone, bulk, everything is being checked. And
Are finding difficulty in walking straight line?
so it is being checked that the patient is able to walk in a straight line or not.
Can you bend a little? Just
So you can see that he was putting the clinical hammer and the ankle jerk in an awkward manner, and the senior consultant immediately stopped him and she will then try to teach him how to perform it. So the students are free to create some mistakes as well, so that they can later on be picked up in reflection, because there will be a lot of learning through observation, learning by doing, and later on learning through observation and critical reflection. All will be in this package. It will be included. And finally, the debriefing will take place in this room.
I became more confident and had things under control.
I agree. Although it seemed quite a bit of challenge at first, but as we went with the procedures and the diagnosis of the patient, now I feel or I have a sense of accomplishment.
Thank you for sharing, and it is fantastic to hear that you learned and gained.
So once this debriefing is taking place, because the students, when they return to the debriefing room, they are overwhelmed, and in order to catch their breath, help them catch their breath, the facilitator is going to ask them, like in this case, ask them to explain in just one word what was their feeling about their experience. So just to limit their words, just to limit their thoughts, and to take hold of their overwhelming, behavior that was quite expected. So after that, it will be further deeply inquired that why do they feel so, and what went well, and what could be improved. So this type of a reflective feedback, a two-way feedback, is taking place over here.
Becker muscular dystrophy. And then his family history also provided us with very crucial evidence. That is, his maternal uncle also had a similar family history and had this similar muscle weakness, and by the age of 25 is now in a wheelchair. And we also did physical examination. Upon examining his calf muscles, it revealed that he had weakness in the calf muscles, so it was difficult for him to raise his leg and his thighs. And his muscle size of the calf muscles was also 30 centimeter, which is more than the average normal size for his age. And then, so he had a calf pseudohypertrophy. And he also found it difficult to walk in a straight line, and his gait was kind of slightly waddling, which are very typical with Becker's muscular dystrophy.
And further, the lab reports said the following things. At first, the creatine kinase levels were elevated, which was almost 15 times more than the normal, and which typically show the breakdown of the muscles. So it points towards the breakdown of muscle disease. And from the electromyography reports, it showed the myopathic changes, which discarded the case of any neurological factors or any factors. So it mainly points towards the muscle diseases. And next, from the genetic testing, it shows that there's a mutation in case of the dystrophin gene, which transcribes for the dystrophin protein. And also, from this mutation, our speculation for this diagnosis went for two cases. It could be either DMD, that is Duchenne muscular dystrophy, or Becker muscular dystrophy, BMD. And finally, from the immunohistochemical staining, it revealed that there was a reduced level of dystrophin in the muscle fibers, and also a small amount of dystrophin was present, which erased the case for we rules out the possibility of Duchenne muscle dystrophy because in Duchenne muscle dystrophy there is a complete absence of the dystrophy.
So what you observe is that the students are taking their discussion to the level of differential diagnosis, which is a senior level for junior undergraduate medical students. But this is how you can see that they are no less than a senior mature student of simulation in a simulation lab, and they are developing their diagnostic skills, and they are being empowered by artificial intelligence, because the learning is coming from there, and they are using that script into practice, and they are dealing with each other. They are not cutting each other. They are waiting for their turn to speak. They are composed, and they are presenting the differential diagnosis like a consultant. So their learning is taking place. They could have picked any disease and started performing on that, given the script was with them. And it would also include what are the signs and symptoms of the patient, how the patient presents. So they can ask everything and incorporate it. So they can become their own teachers this way. So innovation can also be added. Like in this video, you can see another type of innovation. And I will skip the pre-briefing. And I will show you this patient who is presenting with dehydration. And this is the same university where I teach, where they look for this site so that they can have some sweat and present the patient as a patient of dehydration. This is a medical student. So now they are creating this thrill in the scenario so that the situation looks like a near real experience.
Can you raise your hand for me? Can you raise your hand for me? Okay. Okay, perfect. It's a physical examination and also check for signs of expression. Okay, sure. What do you suspect he has? I suspect dehydration secondary to heat. Okay, so let's go with some basic tests. I've been to do a CBC, also the serum electrolyte level to assess your dehydration status, and after that administer IV fluid, normal saline, and monitor it accordingly, and then we will adjust accordingly. Okay, sure, doctor. Thank you.
So now they will be concluding their diagnosis with the help of lab investigations.
So, okay, Dr. Ahmed, let's look into our patient Muhammad Abdul's report. I guess they have been uploaded on the report. All right, let's dive into it. Okay, so coming to the electrolytes, you can see that the sodium is elevated, chloride is also elevated. In the blood CBC, there is a hematocrit level increase and a hemoglobin increase. And now let's look into the urine analysis. Sure. So the specific gravity of the urine is increased, the osmolality is also increased, sodium is also increased, potassium is normal, chloride is normal too. Yeah, perfect. So I got to know that the patient is not stable and is coming here to see us. Can you hear me, Mr. Up? I got so basically what happened was as you were working in the you require.
And finally, here is this debriefing taking place, in which they will reach their final opinion and also summarize what happened, and will also approach the final diagnosis with the help of the consultant. So once we asked the students, they were done, and we gave them their feedback. They also gave us their feedback about what were the strengths of all this activity, teaching and learning activity. So they revealed that they were able to explore some technology like AI technology and simulation technology, and also they use their ability to exercise their clinical skills, diagnostic skills. They improve their teamwork and communication skills, patient handling and patient management, and this way they also developed into better future leaders, professional leaders. And furthermore, it built their confidence, and they were able to face the camera because everything was being recorded while they were performing it. And it's difficult to speak in front of the camera, especially for a student of undergraduate level, but it built their capacity to do so, and their creative element also improved. So their holistic approach developed about the patient and how to handle the patient. And also they learned about the Excel standards, pre-briefing, simulation scenario running, and debriefing. This was a new learning that took place especially. And also their creativity improved, and in-depth search for a particular topic improved, how to look for the signs and symptoms of a disease and how to understand the pathophysiology of a disease. So, and how to interact. So, but there were also, some shortcomings according to the students, the weaknesses, like limiting the video to 20 minutes because they wanted to record a longer video so that they can be more satisfied. And it is difficult to put everything in a small box. And it was a hectic experience as well, although they also enjoyed this experience, but it was simultaneously hectic, and it was difficult to create the video and edit the video, which also carried marks. And then equipment, sometimes their hospitals lacked in equipment a lot, but you can see that with limited equipment, they were able to perform just by introducing some thrill and some creativity. So sometimes there can be issues of audio quality, so then they should be wearing collar mics for that. And furthermore, in weakness, they also talked about their acting skills, performing skills, their coordination, mutual coordination with each other, cooperation with each other. And they also wanted to include treatment in it, but they were limited to the level of diagnosis. Also, they regarded it time consuming, and they demanded more guidance in the form of a PDF format, not just the webinar, but the steps. They should be documented so that while practicing, they don't have to go through the video again and again, and they are able to follow a set pattern that is documented, which can be introduced next time. Also, we asked them about the new learning that took place. So the students said that we improved doctor-patient relationship. We understood about this relationship. We learned how can we use AI in education, and then how to handle the patients and how to be more consistent and real life type of a touch they felt in all this practice. And they were able to manage time, learn how to manage time because they were practicing in a limited time. And they learned about different endocrine disorders as well that they were less familiar about. And then they also mentioned among the new learning experiences that working in a team gave them the confidence and the time management that was learned, and use of video making tools, how to use that. They also learned that, especially they learned about pre-briefing and debriefing, and they enjoyed that learning experience. And clinical exposure was something that they cherished. So they also talked about new learning of pathophysiology and diagnosis of the diseases that were allotted to them, like beta thalassemia, this and that. So confidence and communication, team building, team discussion, and also the different disease states, how to polish their history taking skills and examination skills, and how to manage team within time. So this was something that they learned as new, and learned the real life clinical enacting. So these were the 10 countries that participated in it. And I'm very grateful to my physiology department at University College of Medicine Dentistry. That is a small department, but it is handling huge things in entire South Asian member countries of SAP, which consists of 5 member countries. So I'm grateful to them. So together we achieve more. Thank you very much. And I'm open to any questions.
Thank you so much, Samina. I will open up for first to our panelists if they have any question to ask, and then I could not see any questions in the chat, but if any questions are coming from the participant, please feel free. There's one hands up, Dr. Abdulaziz Ansari. Probably we might not be able to allow you to speak. So if possible, can you please write down your question in chat? And with that, I will go to our panelists for their comment. Yes, Dr. Akhtar, I see you on mute. Can you please provide your valuable feedback or comments or any clarification you need?
Thank you, Professor. It was really a very, the topic which you have discussed, especially with the limited resources, it has shown that no matter what areas you want to improve, and if you have the passion, you can do it. I know in this part of the world, like North America or UK and Europe, we were blessed with some resources, and then we can use that. But I think you're doing equally good and perhaps better than us in terms of teaching and training and educating your junior colleagues. So kudos to you and your staff. And
Thank
obviously you get a very good teacher, which is continuously blessing you all the time.
So kudos to my teacher.
Okay. So my question to you, do you see the change in a change in the year to use the simulation as a teaching tool? When we were growing up and when we were learning, we were just more using the patients, and thank to those patients who has given us the opportunity to learn from them. But obviously, even for a simple IV line, we had to poke the patient several times. But now with the help of simulation and mannequins, all those things are very possible, that you can prepare the student up to a certain level where you can let them use the human to move forward. So what is the atmosphere is there for simulation, especially in the Lahore part?
Yeah, because you could see that in the second video, they were my own students. And in the first video, they were students of another member country of SAP, that is Nepal. So I could see that the students, they developed this confidence due to this safe learning environment, which is the heart and soul of simulation practice. So when they are given a safe learning environment, then their capacity can build very easily, and they are given this freedom to make mistakes, and they are also given this assurance of not being judged, and they are also given this basic assumption that we consider them intelligent people, and they will not make some deliberate mistakes, and they are given a map of what is going to happen, and what they are not given any a lot of surprises, except for what they can add for themselves for their own learning. So this way, I think that these students have a way to go, and they will become more safe doctors than where we have reached at a later time. They will be reaching there at an earlier time. This is what I believe. I hope so.
So connecting with my previous question, I mean, I know the students are already eager to learn, but how about our senior colleagues or consultant level? What are the challenges you face to bring them on board so they can participate in simulation teaching?
Actually, it said that if nothing else work, throw down a challenge. So here exactly this happened, that When things were not working, we thought of giving them a quiz, a competition. So in order to make their teams win, the facilitators also jumped in, and they tried to improve their scripts, and they tried to review their videos in whatever limited time that was offered to them, because it was open, because the purpose was not so much summative but mainly formative. The purpose was assessment for learning, not just assessment of learning. So it was a it was a qualitative feedback as well, besides this quantitative, and they were given this qualitative feedback about how they could improve, and where is further room for improvement. So once they understood and even shared the videos of each other, so they were able to learn from each other. So mutual learning was also taking place. And then also this is a big gift by the students for the communities of practice, that the faculties, they can be receiving those videos because we have their free consent, and they can show it to their faculty and their students so that they can also create this type of videos. And seeing is believing, and once they see, they learn, and they will then innovate.
Thank you.
Thank you, Dr. Akhtar. Samina, there is a question by one of our attendees, Dr. Shakil, that what is the feasibility of simulation in high traffic hospitals in Pakistan? Like, you can share your thought, and if anything, I can also respond to that.
Right. So thank you for this good question. I believe that the high traffic hospitals are the public sector hospitals in which there are 3 patients on a single bed. So, but the patients, they are not something, they are not the meat to slaughter. They are human beings. So they have their own value. And now the awareness is improving, and the literacy rate is also going up. So the patients will not allow any medical student to just come and examine the patient. So they have their own limitations now, so, and reservations now. So that is why it will always apply that if the doctors are, on the other hand, too busy to attend the students, and they are caring after the patients, especially the clinical doctors, then the basic sciences should assume this responsibility of introducing simulation in the problem-based learning sessions, so that the students, they are able to equip themselves with all those skills before they actually land into the clinic. And this will reduce the burden of the clinicians as well. And with the making of these videos, again, the job will become easy before performing the examination on a real patient. They will be examining the same patient in a simulated manner, so that they know about what to expect over there, and how to then handle that patient, and how to diagnose and treat and everything.
Thank you, Professor Samina. And I would like to add that as we make our learners learn by any other method, simulation is another method. It is not a add-on thing, it is an integrated thing. That's why as early on as from first year medical student, it should be introduced. So it should not become a heavy investment when the learners go to the medical or clinical specialties. So then high traffic, it doesn't matter whether it's a high traffic hospital or a low traffic hospital. Dr. Zair, for your last comment, I know we are 1:01, but I want to hear your thoughts, and then we will close the session today.
First of all, thank you very much, Professor Samina. A very great and very thoughtful presentation. And of course, Dr. Jabin, really, she was quite instrumental in doing these things happen. So I think we need to think out of the box. So how we are facing the storm of technology, just a couple of prediction. Now they are predicting that the children who are born in Canada right now and the US, their average life expectancy will be 150 years. Okay, number one. And number two, from the anthropic, very soon 50% of the developed world population will be jobless. That's the storm of technology, how hard it is going to hit everything and where we are. And I think that is the extreme end with very limited resources. And on the other hand, these are the prediction. We are in the storm of all of these things. And we are a very strange and tough generation who started their career from a very, very basic level. And now we are facing the storm of artificial intelligence. Now, like the last 2 weeks, the rogue artificial intelligence, that it is becoming immortal. It's not going to get it killed. So these are the scenarios, the external factor and the macro environment, technological environment, and about the medical profession. Now, no one can tell really what is going to happen for your young one, your grandchildren, your children are 5 to 10 years. I don't want to raise the alarm, but this is a very, very difficult question. But at least you are lucky, like the medical student, that you are relatively protected in the near future. But I think we need to think and think again really how to handle all of these things. So the time is really over. And once again, thank you to all of you, and over to Dr. Jabin for a formal closing.
Yeah, thank you. I am seeing a lot of comments, good kudos and comments. Thank you, Professor Samina, for sharing. I think this is the first batch of mine who did the certificate course, and everybody did such a amazing projects. Dr. Rizwan is here as well, and Samina is the one which bring the simulation to the undergraduate education, to the basic medical sciences. So thank you so much for showing other how simulation can be used in undergraduate education. Achya is one of the students. She's asking, what is the future of simulation in medical education? I would say everything needs simulation to be done. It is just an example that would you start or sit with a driver who have never driven a car with a car instructor or with someone teaching them a car? If your answer is no, then the same apply. Do you want to be treated by a doctor who have never done that before doing it on you as an actual patient? So this is the role of simulation in a nutshell. With this, I will close this session. Thank you so much for your attendance, for your participation, and we will be looking forward for another very informative session. Take care. Allah Hafiz. Assalamu alaikum.
Thank you so much. Highly
Allah
blessed.
Hafiz.